Thank you, Jane, and I have nothing to disclose. And so today I am going to talk about some of the changes that we've seen in cystic fibrosis. In particular, what I see at Seattle Children's is we're really involved in the sweat testing. And so we've seen some increases in our sweat testing in the past couple of years. And so, in order to support this effort, I wanted to take a deeper dive into what's been happening in this field and kind of understand it from more of a global perspective. And so I'm going to kind of share a little bit what I've learned. This is an area that kind of is involved in multiple areas within the Department of Lab Medicine and Pathology and things like that. And so after, if you want to kind of share some of the changes that you've seen, that would be great. So here are my learning objectives. And so I'm going to give you an update on testing and treatment options for people with CF. And we're going to look at some of the trends in the sweat chloride testing. And then we're going to examine some of the barriers for equitable treatment and access to care across the diverse CF populations. And so for an outline, I'm going to give a little bit of a background in CF and then talk about the genetic analysis and modulators. And then I want to go into a little bit of depth into the newborn screening because that has recently changed, and that's why we've seen some increases in the sweat chloride testing. And then I'll talk about the sweat chloride testing itself, and then there's also some updated guidelines that are coming out as well, and so I wanted to put them on your radar. So it's kind of nice to maybe begin with a case for us to think about as we're kind of talking about this information. And so this is a case that I kind of pulled from recently. We have an 8-week-old male of Middle Eastern descent. Newborn screening results had an elevated immunoreactive trypsinogen, or IRT, of 170 nanograms per mil, but no DNA variants were discovered. And newborn screening in Washington uses a panel of 41 variants. And so the newborn screening was therefore normal. For this patient, he was seen by his primary care provider, and this patient had failure to thrive. He had not been able to gain weight despite switching from breast milk to formula, and he frequently had diarrhea. And so he had a pretty astute primary care provider. She repeated the immunoreactive trypsinogen, which was again elevated at 170 nanograms per mil. And then she decided to pursue sweat chloride testing. And the sweat chloride testing result was 100 millimoles per liter. So we'll come back to this case and discuss it, but kind of keep this in the back of your mind. So a little bit of a background on cystic fibrosis. So cystic fibrosis is an autosomal recessive disease caused by variants in the cystic fibrosis transmembrane conductance regulator, or the CFTR gene. And so it's this ion channel that allows chloride and bicarbonate through, and it kind of balances with the ENaC, which allows sodium. And so it's kind of very important for the balance of water and salt in multiple tissues. And so it's a multi-system disease. And so shown in the picture, you can kind of see a little bit how the ion channel works, letting the chloride through, and then the ENaC channel balancing it. And so if there isn't a balance in the water across the membranes, then we can have this sticky mucus buildup that can happen in the lungs. And in fact, there's many different areas that this disease can sort of cause issues. So of course, in the lungs, there's progressive pulmonary disease. That's of major concern. And then there can also be neonatal jaundice and liver disease. There's excessively salty sweat because the chloride or the ion channel isn't able to balance the water properly. In some neonates, there's meconium ileus, and that can cause a falsely low IRT value. So that's something to kind of be concerned when a baby is born with that clinical picture. It can also cause malabsorption and distal intestinal obstruction syndrome. There's also other airway issues like chronic sinusitis, and then exocrine pancreatic insufficiency, as well as poor growth, malnutrition, and then male infertility. So there are a variety of different clinical manifestations that this disease can kind of affect. And so I wanted to just give a little bit of history about cystic fibrosis. So in 1938, Dr. Dorothy Anderson characterized CF in children. And the Cystic Fibrosis Foundation actually formed in 1955, so very early. And they began their patient registry in 1966. The gene for CFTR wasn't sequenced until 1989, and that kind of really started the ground for the research. And the drugs, or the modulator therapy, which we'll talk about in a little bit, they started development in the early 2000s, and even the Cystic Fibrosis Foundation, CFF, was a major sort of backer in kind of getting that initiative going. And then also of importance to note, in 2010, there was universal newborn screening in the US. So this is kind of a diary entry from a patient with cystic fibrosis. It's kind of a cute little thing. It says, "Today is the most best day ever in my life. They found a gene for cystic fibrosis." So this kind of takes you, or kind of shows you a glimpse of how patients felt when they were trying to figure out what was going on initially, because initially this was a disease that severely affected children. So when we think about CF presentation, we have to kind of think about it as a spectrum, because remember, the ion channel is kind of one of the main culprits of the disease. And so the theory behind it is, depending on how much function is left in the ion channel, sort of correlates with the severity of the disease. And so here, there's kind of just another, a kind of a useful depiction where there is CF function on the y-axis, and then kind of showing the different progressions to the disease. So of note, there are heterozygotes, which are carriers of the disease. So they would only have one defective copy of the CFTR, and then the other copy would be normal. And so just important to remember this, because when we think about screening for CF in the future, remember that we have a large carrier population. And so it's really important to think about balancing how do you identify people at risk for CF and not capture a lot of carriers. There's also this, on the spectrum, a disorder called CFTR-related disease, where maybe a patient only has one organ affected. Maybe they only have pancreatitis, or they're a male who is infertile. And then way down at the extreme, we get cystic fibrosis, where there are two defective copies of the CFTR. And we can have pancreatic sufficient and pancreatic insufficient populations. And so this is kind of a useful schematic for how to think about the genetic variants. Now, this is a very simplistic view. We know now that often the genetic variants kind of target multiple categories, but this is kind of a nice way to view it. So when we think about the genetic variants, this protein has about 1,500 amino acids, and there have been over 4,000 variants identified, so it's quite diverse. The Phe508del is the most common variant. And as I said before, the severity of the chloride channel dysfunction varies widely with different variants. And so how they classify them in this figure, they classify them by 1 through 5. And so in this figure, and you can't see my mouse, so I'll just kind of talk through it. So we have class 1 through 5, and the class 1 through 3 are the more severe presentations. And so this is thought to cause more classical CF picture, though we know that variants might kind of fall within different realms. And then the class 4 through 5 have a much milder presentation. And then so you can kind of see in the percentages some of the estimates for the number of patients with the different variants. And so for the class 2 and 3, especially the class 2, that's where the Phi 508del falls into. You can see it has a high percentage. A lot of people with a white background carry this variant. It's kind of more popular or more common in the US and in Europe. I looked into a little bit as to why that would be. It's thought to have probably arisen from like a founder effect. It's not very certain, but it does appear more often than what you would expect in the population. And so that's kind of one of the common variants that is screened for. What's really nice about data for the CF population is that it's all compiled in the CFF patient registry. And so they have all of this data that they collect from people with CF. And then every year they issue an annual report. And this report is just full of a wealth of information. And so showing here, I'm just putting up some of the demographics that they've found over the years. And so you can see that the top line has the people diagnosed with CF. You can see the newly diagnosed individuals. And then really important for this talk is looking at the category of race. And so if you look at the different percentages of the diverse population, you can see that we have a growing number of African American and other race and other ethnicities, such as Hispanic, that are growing within the United States. And the reason that this is important is that because these different racial and ethnic backgrounds may have different variants that would cause CF, and we have to kind of be aware which ones we actually screen for on our genetic panels and which ones we actually maybe don't. And so we have to be cognizant of that. So there's growing diversity in the CF population, and it indicates that there's going to be a growing diversity in the variants detected. So the CFF patient registry is very useful, and it has a wealth of data, and I'll present some of that here. Another database that's really kind of interesting and fun to kind of review and look at is the CFTR2 database. And the CFTR2 database kind of contains all the information from the CFF patient registry, and it condenses it so that providers or even the general public can put in 2 different variants and see what to expect for a given patient. So, and this database is constantly growing. So to date, they had 1,085 CF-causing variants. They had 55 variants of varying clinical consequence, and then 27 non-CF-causing variants. And so this is an international collaboration from the CF registries. And then providers and the public can enter 2 CFTR variants to assess the disease risk. So just to give you a little idea of how this works, I put in a couple of variants just to kind of see what information it can give. So at first I put the Phi 508del and the Phi 508 cysteine. And it said that this variant combination does not cause CF because the F508C is a normal variant. And so it also states that there are 5 patients with this variant in the CFTR2 database, and based on the clinical information, laboratory experiments, and analysis of the healthy groups, this has not found to cause CF. And here's an example of a different variant. So this is again the Phi 508del, and then the arginine 117 histidine. And it says this variant sometimes causes CF. And so this kind of describes some of the complexities with finding and identifying CFTR variants, because for the R117 histidine, it's really also dependent on the length of the poly-T track. And so if there are 5 T's in the poly-T track, then it is more associated with disease. But if there are 7 and 9, then it's not associated with disease. So it gives further information that the provider can look for to kind of help correctly diagnose a patient. It also gives potential medications that the patient could take, the sweat chloride concentrations, the lung function, and the pancreatic status. So it's a wealth of different information. And with all this genetic data, kind of what I described a little bit when we talked about the summary statistics, it also in the CFF patient registry, they talk about the prevalence of the Phe508del in the different groups. And so here I'm listing different races and ethnicities, and it shows the total number in the database. And you can see that for the white population, the prevalence of the Phe508del is about 90%. But once you look at different races and ethnicities, it drops down to 60 and 70% and 67%. And so it is much, much lower. And so it's just important to be aware of this, because in the past, way back in the past, for some genetics, they used to only screen for the Phe508del. And actually, when we talk about newborn screening, there's still one state that is only screening for the Phe508del. And so we have to kind of be aware that as our population becomes more diverse, we have to kind of keep adding more variants to our list. And this is a really good resource that kind of talks about the top variants for these different races and ethnicities. And another kind of interesting trend with cystic fibrosis is sort of the predicted median survival in years. And so you can see back when CF was first described, this was definitely a disease of childhood because children often died early in age. And you can see through the advances of the different treatments, pancreatic enzymes, airway clearance, using antibiotics and things like that, you can see that the median survival in years has increased. And then at the end, now we kind of are into a new stage because now we have more treatments, and that's CFTR modulators. So CFTR modulators are compounds that help the protein function better. And we'll talk about some on the next couple slides. But you can see that now that more modulators are into play, that the expected median survival is going to rapidly increase. And so this median predicted survival of 61 years was kind of before the modulators were on the market. And now that they're out on the market, we're expecting that people with CF are going to live longer and longer. And so they are also going to need more healthcare as they get older to kind of support them along their journey. And so just to go through and talk about some of the CFTR modulators. So one of the first CFTR modulators was ivacaftor. And ivacaftor was for a gating mutation. So ivacaftor was approved in 2012. And the modulator is a potentiator that helps the channel stay open longer. So this is typically only works for individuals with a gating mutation or a gating variant, which is roughly about 2.5 to 5% of the CF population. The next modulator combo that was approved was lumacaftor and ivacaftor, and that was approved in 2015. And so this acts as the potentiator and the corrector. And the corrector helps by getting more protein to the surface of the membrane. And so with this combination, it could be targeted for 2 copies of the Phe508del variant for those patients, which was in 2015 about 50% of the US population. So it was able to kind of help a big population, but we know that our population is becoming much more diverse. And this was approved around the same time. This is ivacaftor and tezacaftor. And this is a potentiator and corrector. And then sort of the last one that was approved, and this one has been kind of a big game changer in the CF field, is the elexacaftor, tezacaftor, and ivacaftor, or ETI for short, which you'll see in many of the papers. And for this, it's a combination of molecules that can act as potentiators and correctors, getting more protein to the surface. And for this drug to be prescribed to a CF patient, at least one copy of the Phe 508del must be there, or they have to have a variant which shows that it can improve the function of the channel of at least 10%. So we all know FDA studies take a long, long time to do. So to do these studies for ETI, they had to initially do the clinical trial to get it approved by the FDA. But since then, the FDA has been a little bit more lenient in approving other variants if they can prove with in vivo data, usually using cell-based assays, that it will work for that patient. And so that's been a very big improvement and very fortunate for patients with other variants. And so if we look at the distribution of CFTR modulators for people with CF, so CFTRM is CFTR modulators, PWCF is people with CF, you can see the rapid growth over the years. And so you can see from 2015, about 10,000 people were treated with modulators. And now up to 2023, we have over 25,000 people treated with modulators. And the dominant one is ETI. And now I'm going to show this graph in a little bit different way. So now the colors have changed. They're still showing the different modulators that were sort of used for treatment. But then this graph also adds patients who would have been eligible for modulators but weren't prescribed them in the database, and then patients who are ineligible for modulators. And so you can see that there's still a remaining 10% in each bucket that still aren't getting the treatment of the modulators. Now it might be because maybe the ineligible ones, maybe their variants are not classified to receive treatment. And for the eligible but not prescribed, that's something that the CFF Foundation is really trying to kind of determine what's going on. Do they have milder symptoms? Can they not afford it? Because the modulator therapy is very expensive. They're trying to kind of figure out why aren't people getting access to these medications? And when you look at the demographics for the treatment for people with CF in the US, so I kind of put the data for all the patients in the registry. So that was what I showed you earlier, the percentage of white and then the different races and ethnicities. And so you can see the percentage of CFTR modulators prescribed, the percentage of eligible but not prescribed, and the percent of ineligible individuals. And so when you look at the percentages of ineligible individuals, you can see that there's a disproportionate number of those who are Black and Hispanic relative to the percent that have CF that cannot be prescribed modulators. So this is sort of, it's sort of important to keep looking and classifying those different CFTR variants, because these patients definitely need treatment and we definitely need to keep them on our radar. And this just shows kind of a global view of the different CF registries across all of the world. So not all countries have CF registries. Definitely, this is another push by the CFF Foundation to kind of get countries to start listing people in a database so that we can learn more. Because if we have the data, then we can improve sort of the clinical care, especially in the US when we have a diverse population coming here. And then just to kind of show what treatment looks like for these different populations, you can see in wealthy countries like Europe, the US, Canada, Israel, and Australia, the total population and the total diagnosed, the red and blue, is sort of similar. And then the total treated is less, but at least there is a purple bar that you can see. And then when you look at the rest of the world, you can see that there's a lot of individuals who are not getting diagnosed yet and who are not getting treatment. Okay, so that was our journey talking about the diagnoses and with the modulators. Now I want to take a turn and talk a little bit more about newborn screening. So since we started with a world map, or ended with a world map, I'll start with a world map. So these are the different places where newborn screening exists throughout the world. And so for newborn screening, we have a couple of different tests that are typically used. We have the immunoreactive trypsinogen, or the IRT, and that's an enzyme precursor made by the pancreas, and it's elevated in newborns with CF. And it's thought to be elevated because it's a marker of pancreatic injury. It's also not reliable in neonates with meconium ileus, and it's a non-specific elevation with perinatal stress too. So it can be elevated for reasons not related to CF. It's also elevated in preterm neonates. And so one of the recommendations from one of the newer guidelines, which I'll show in a little bit, is to use a floating cutoff for the immunoreactive trypsinogen assay. And then also to establish a very high IRT referral strategy. And so for the floating cutoff, the reason that this is recommended is that this is an ELISA, that's a lab-developed test. And so with this kit, it's not really strictly controlled by the FDA. And so there is lot-to-lot variability. There is some temperature sensitivity issues when samples, usually sent by dried blood spots, are maybe sit out in the heat or maybe in the cold. And so one of the recommendations is to use a 96th percentile cutoff rather than a fixed cutoff. And then the very high immunoreactive trypsinogen referral strategy is just to kind of help catch patients who are at a very high risk for having CF. So if the IRT is very elevated, then they should probably refer to a CF clinic right away. So the IRT is one part of the newborn screening, and then the DNA variants is the second part. And so as I said, there's almost 4,000 known variants. The Phe508del variant is the most common, and depending on your patient population, it has a 56 to 90% sensitivity. Some people might say, well, why don't you use the ACMG 23 panel? But that actually isn't very significantly better, depending on your patient population as well. That can have a 47 to 93% sensitivity. And so really the gold standard is to look through the CFTR2 variants and to screen for all those variants. Now that's very difficult, we know from a lab standpoint, but it's very important to kind of know your patient population and to kind of communicate with your providers so that you know which ones are being missed and if more should be added to the panel. Now we have universal newborn screening in 2010, but that doesn't mean that all states do it the same. They actually have several different strategies. So there can be IRT and then a second collection, IRT2. There can be IRT followed by DNA. There can be IRT, DNA, and then extended genetic analysis, and so on. And so different states have different strategies, and then different states also screen for a different number of variants, which I'll show that in a little bit. And so although we have universal newborn screening, it's not done the same in every single state. And here's a graph kind of showing an evolution of CF newborn screening. And so you can see in 2010, it started with more IRT and then a second collection for IRT and then maybe DNA. And the trend has been to shift towards IRT and then move to DNA. And so I'll just kind of mention that that was actually one of the new changes that happened in Washington. So Washington used to do IRT, IRT, DNA, and then recently they switched to IRT, DNA. And so we'll talk a little bit about why that is when I get to the slide, but just to give you a heads up. And when we look at the number of diagnoses for CF by newborn screening, we can see that it's about 54% of all new diagnoses. But if you consider the patient population that's less than 6 months, then it's about 85%. So it's catching quite a few individuals, but it's still missing some. And so it's really important to have good communication with the different pieces that are at play in helping to diagnose these children so that when there is a missed case, we can learn from it. And so this shows the variants detected by newborn screening by state. So Washington has, you saw 41 variants from the case. And so you can see that the variants drastically differ across the different states. And so you can see some screen for over 140, some screen for 70, and some screen for 60 or 41. And so as you might guess, the more diverse the population is, the more important it is to add different variants to that screening in order to catch the patients with CF. And so here was an interesting study done by Dr. McCary. And so she just looked at she took the CF database, and then she looked at the likelihood of CF being diagnosed by NBS. And so the properly diagnosed would have been 2 variants found. Potentially diagnosed would be 1 variant found. And then not diagnosed would be no variants found, but they still have CF. And so she looked at a bunch of different panels in her paper, and this is just showing one of the different panels. But you can see how the different racial groups are very much affected by the different number of genes or variants screened for in this panel. And so this is something that we really need to be aware of in the lab when we want to sort of provide equitable care. So for the Washington newborn screening algorithm, so they started with IRT, IRT, and then they moved to IRT, IRT, DNA. So this does require a second collection. So anyone in the lab probably knows what happens when you need the patient to come back for a second collection. How well does it work? Some people do and some people don't. So you get some lost to follow-up just by needing a second collection. Also, sort of when reading the articles, what was kind of hinted at is that the IRT, IRT DNA probably minimizes carrier detection. So it's probably improving the specificity of the overall test performance. But remember, for a screening test, we really want to improve the sensitivity. And so, it's really a trade-off with this testing. You can either go for specificity, not get so many carriers, or sensitivity, and then you're going to get more carriers, and then you're going to get more in this inconclusive bucket, which we'll talk about at the end too. And so it's really been a balance, but recently Washington has switched to IRT DNA. So they get the dried blood spot, they run the IRT, and then they'll screen for the DNA variants. And if there are no variants, but the patient is symptomatic, they'll be referred for sweat chloride. If there's no variants, but they have that very elevated IRT, then they'll also be sent for a sweat. Or if they have the high IRT and then one variant detected, then they'll also be sent for a sweat. If they have 2 variants detected, they'll be sent right to the CFF center to kind of start the discussion about that pathway. So let's talk a little bit about sweat chloride testing. So sweat chloride testing is acceptable in infants greater than 2 days old and greater than 2 kilograms. Really, the limiting factor is being able to get the band around their leg or their arm. We need the band to kind of be properly situated on the baby. And it's done by pilocarpine ionotophoresis, which stimulates the sweat secretion. So for 5 minutes, the sweat is stimulated, and then we put on this macroduct collector, and we collect the sweat. And so you can see there's the collector, and we have like a little blue dye, and you can see the blue dye, that's the sweat coming up into the collector, and it's circulating around and around and around. And so we hope we get a good sweat collection, we remove that coil, we push it into a PCR tube, and then we bring it to the lab for an analytical measurement for coulometry for free chloride. And so that's sort of the process. We follow the CLSI guidelines. So for a given patient, we do both sides, both legs or both arms, depending on which ones fit, because really we want to get the best opportunity to collect enough sweat so that we can give the patient a result. It does happen that sometimes the patient doesn't give enough sweat. We need 15 microliters minimum to give a result, and then we have to reschedule or they have to come back for another appointment. So for the sweat chloride interpretation, here's just the different interps. So greater than 60 is consistent with cystic fibrosis, 30 to 59 is indeterminate, and then less than 30 is unlikely CF. Now, even though this testing is a little bit older, we in the lab have noticed that there are opportunities for improvement because, no parent likes to get that QNS, didn't get enough sweat. And so I'm just kind of showing some research from WashU. And so, the CLSI guidelines state that we have to get a minimum of 15 microliters in order to test it, but our actual analytical instrument only needs 10 microliters. And so this paper kind of argued that maybe we could still test if there's 10 microliters and get a result. And then also they thought about considering pooling samples. Sometimes you get a little bit of sweat from the right, a little bit of sweat from the left. Could we pool them together and still get a valid result? And so kind of shown in that graph is the different sweat chloride concentrations from the left arm and the right arm. And you can see that they follow a very consistent trend and they're very similar. And so these were just ideas kind of put out by that research group. We would love it if we could because parents do not like a QNS, but we will see what happens in the future. So let's get to some of the trends that we've seen at Seattle Children's. So for Seattle Children's, remember this is an hour-long patient procedure, so we have to have a dedicated room, a dedicated lab assistant to do this testing. So in 2021 and 2022, we had about 200 of these appointments throughout the year. In 2023, we had 328, so it was a little bit of a rebound after COVID. But then in 2024, we still had quite a high amount of sweats, around 300. And so if we break it into the different age groups, the purple is less than 1 year old, the gray is 1 to 18, and the green is greater than 18. You can see that in 2023, we had kind of the rebound in like the older children, 1 to 18. But then once we hit 2024, now we are seeing a lot more babies. And so we're seeing a lot more babies because of the change in the Washington State newborn screening algorithm. So they've switched their algorithm, they're doing IRT DNA, and so we're getting a lot more referrals. Also, of note that's kind of interesting, we are seeing more and more adults getting sweat testing as well. And so here are just a couple trends from the national database. And so if a patient has a 508del mutation, or a variant, I mean, you can see that the sweat chloride is about 100 millimoles per liter. But over the years, if they do not have the Phe508del variant, you can see that the sweat values have started to decrease. And so as people are getting better at identifying these pathological variants, we can see that our sweat concentrations are slowly changing too. And so it's going to be a good idea to keep an eye on this in the future and make sure that we can kind of understand what's going on. And then there's also a lot of active research with the sweat chloride testing. And so this is from the part of the group that works at the Seattle Children's Research Institute. They have sort of done these observational studies in children who, before they've gone on modulators and after they've gone on modulators. And so shown at the left, you can see the difference in the ivacaftor population, and then the lumacaftor ivacaftor and the tezacaftor ivacaftor. And so what sort of how the research kind of views this is that the sweat testing is sort of inversely related to the CFTR function. And so what they see, at least from the trends in this paper, is that if there's a little bit of CFTR function, it looks like the modulators can help correct a lot more than when there's more severe variants. And so this was for the single and the dual medication. Once we go to the triple, the ETI, now you can see the orange line. This is a little bit different way to view it, but now a significant portion of the populations have sweat chlorides that are less than 60. And so how they view this research is that when the sweat chloride changes and it's just minimally, it could be that the patient needs further therapeutics or further things to kind of help that ion channel work better. So I'm also going to just briefly cover two research-based tests that are mostly more available in Europe. We don't see a lot of them here, but they're kind of interesting. So there's one test, so this would be sort of orthogonal to the sweat chloride testing, called the nasal potential difference, the NPD, where the patient is connected to electrodes in the nose, and then it's bathed with a solution. And really what this test is doing is it's measuring the ion channel activity. And so shown at the top, you can see that somebody with normal activity, you can see that the ENaC activity is in red and the CFTR activity is in blue. You can see how it normalizes. And then on the bottom, you can see somebody with CF, how you could pinpoint that that patient has an issue with their chloride channel. And so this is one research-based method that's available at highly specialized centers. And then another method that's more of an organoid model is this interstitial current measurement. And so for this, they get rectal biopsies and they measure the current using sort of these different molecules to stimulate the CFTR and then block the ENaC to kind of see if the current spikes. So you can see in healthy individuals, you see a signal. In individuals with CF, there is no signal. So those are some research-based methods. And then lastly, I just want to touch on some of the new CF guidelines. And so one that Dr. McGarry notified me about, which thank you, is that there are new CF guidelines for NBS, and these are open for comment. And so these guidelines are really sort of developing more of a standardized care to increase the timeliness, sensitivity, and equity in diagnosing infants with CF. And so for these guidelines, they recommend a floating IRT cutoff, a very high IRT referral, consider extending your variant panels based on your patient population, perform testing, the molecular testing, at least twice per week, and then use tiered testing for genomic analyses, and then also notify CF centers and the PCP of abnormal results. So these are open to comment if you would like to read them and kind of see some of the changes in the works. And then another guideline that was recently published was for the cystic fibrosis transmembrane conductance regulator related metabolic syndrome, it's a mouthful, or CF screen positive inconclusive diagnosis, which is how it's known in Europe. So basically, this is the inconclusive diagnosis of CF. So maybe the patient has an IRT, a high IRT followed by less than 2 disease-causing variants, or maybe the sweat chloride was normal. And so these patients would fall into more of an inconclusive diagnosis. And so the question is what to do with these patients. And there are some recently published guidelines kind of talking about the clinical care for these patients. And so really it's to rely on clinical evidence, to consider more thorough genetic analyses, and at least for me, which is good to know, they might get repeat sweat testing every year until the age of 8 to kind of screen to see if this patient does convert and have active CF. And so that's good for me to know to kind of plan for the future. So if we come back to our case, remember our 8-week-old Middle Eastern male, we know now, hopefully from the talk, that the DNA variants that were screened weren't sufficient for this patient, that this patient likely has CF, he started getting treatment, and the genetic analysis was pending. And so it was really great that the PCP was on top of it and knew the next steps for this patient. So hopefully I've accomplished my learning objectives. And I just want to thank Jane in the SCH pathology department and Sean. Melinda Rankin is our lab assistant who does many of these sweat procedures, and she's really great with the kids. And of course, the Department of Lab Medicine and Pathology, and thank you all for coming. The SCH CF directors are very, very helpful in helping to maintain this test and helping when parents call with questions. Theta, Amy, and then Ron. Ron has since retired, but I appreciate his expertise so much. The pulmonology team at Seattle Children's. And then I also interact with the UW CF director, Sid, he reviews all of the abnormal adult sweat chlorides. And so I'm really thankful that he allows for the follow-up for those patients. And with that, I'd like to thank you for your time, and I welcome any questions or any comments of trends that you've seen in your labs.
Yes, so we'll talk. Thank you. You alluded to the, or you showed the trends that very recently you've been getting younger patients, quite young patients for the sweat testing. Are those more likely to have QNS samples, or more likely to be challenging in the testing?
Yes, it can be a little bit more challenging with a baby because it really kind of depends how well you can get the collectors situated on the baby and collect the sweat. They do have a little bit higher QNS rate. The CFF Foundation likes your rate for the older patients to stay less than 5%. It's a very strict criteria. It's actually very hard to meet because you're getting a variety of different patients. Some might be hydrated, some it doesn't work very well, some maybe the collector moved a little bit. And so we do have a slightly higher QNS rate for babies, though since we are also screening more individuals because they've lowered the specificity and increased the sensitivity, we also are getting a little better at it too, because we have a little bit more practice. And so I think we're trying to kind of balance it, but it is something that's definitely closely monitored. And when they do get a QNS in the report, we actually sort of have guidance for how the family can reach out to the CF Center at Seattle Children's or the CF Center at UW, depending on the patient age, if they want kind of further advice. Yep. Bill.
And what's your ebooks mentioned sweat sodium? Is that a thing?
Sweat sodium. Well, we don't do it at Seattle Children's. We did it once. Yeah, we typically don't measure the sweat sodium. We typically only focus on the sweat chloride. Yeah, we haven't looked into it too much though. Yes.
This sort of for the genetics question, so not sure I could let the answer. But for instance, for the case, like we know that our panel doesn't include the relevant genetic variant. How easy is it to then get, or is it easy at all to get a new genetic variant once they finish up the genetic analysis for them and identify what the variant is? How can that get added then into the panel, or is it like a very long complex cost?
Yeah, I mean, I think, you know, and molecular can probably speak to this. Adding more variants to the panel probably takes some work in validating it. For newborn screening, I don't know how feasible it is for their process to add variants to the panel as well. And so I think it probably takes quite a bit of work. And so really, you know, having that good communication, making sure that people are talking to each other so that that patient isn't missed by other maybe clinical symptoms or lab results is really important. Yes.
Do you think there's value in standardizing the panel as opposed to US? I think there's such a huge issue.
I mean, I think in the ideal state, the newborn screening would go to NGS, right? And kind of fully sequence the CFTR gene so that all patients could sort of get an accurate diagnosis. And so I think definitely that's where the field wants to go. But when you have kind of all these different labs in the different states doing different things, I think kind of starting with guidelines and standardizing the practice is a good place to start. And then definitely, I think the providers, the CF centers, the CFF Foundation, that's where they're pushing because they do want more equitable diagnosis and care for these patients. So that would be the ideal state in the ideal world, and hopefully one day we get there.
So, I mean, for example, for the one state that while they spend with mutation, you have a sense of what the barriers are for them to expand?
No, yeah, I didn't look into it for the one state screening, the one variant. I mean, in the past, other states have done it too, and so they just haven't developed their panel further. And so, yeah, it's newborn screening. Labs likely have certain barriers to implementing new tests. They probably have to consider cost as well. And so it's probably a hard thing to do, but it significantly improves patient care. Yes. Yep.
For, in the future, let's say when NGS is implemented, and I guess, what do you see the future for sweat chloride testing? And kind of as a second part of that, when you show the data being a terms modulator for sweat chloride, are different levels prognostic in terms of disease course when we now know the true mutation, but might not know how?
Yeah. I would say that I view sweat chloride as sort of evidence. You can use it as evidence that patients have cystic fibrosis, and you can use it as evidence that maybe modulators are helping. Should it be used as sort of a diagnostic or as a marker to say patients should or should not get treatment? I don't know that we're there yet because CF affects so many different organs, and maybe for one particular variant, it doesn't affect the skin as much as it might affect other organ systems. And so I think we have to be careful how much we read into the interpretation. I think for a research setting, it's totally fine. For clinical care, we should be cautious. Awesome. Well, thank you guys so much for coming.